Reproduction Part 1. As we get into studying the female body and also getting into learning all about kids, it really is smart for us to go back and do a little bit of a review on the anatomy. We understand that puberty ends in males when the mature sperm is formed, or when in females regular menstrual cycles start to occur. In males, we see a general growth spurt and an enlargement of the penis and the testes as they begin this change into puberty. Testosterone is the primary male hormone, but the levels don't fluctuate like they do in a female. Not that females have the testosterone, but female hormones fluctuate. The levels do decrease with age, up to about 50% by age 80 years. Testosterone is going to cause the male to grow taller, become more muscular, develop secondary sexual characteristics such as pubic and facial hair, and a deeper voice. But it can also cause increased muscle mass and strength, promote growth of the long bones, increase their basal metabolic rate, enhance production of the red blood cells, enlarge the vocal cords, affects the distribution of body hair, and it also increases production of sebum, which is a substance that may cause an increase in acne. The genitalia involved with males includes the penis, scrotum, testes, vas deferens, prostate, seminal vesicles, the ejaculatory ducts, the urethra, and accessory glands. And just a reminder of where you find all of these particular items in the male. With females, the first outward sign of puberty is going to be breast development. We talk about menarche as being the very first menstrual period that the female has, and it will occur 2 to 2.5 years following breast development. The female growth spurt will occur at during puberty, but it does end at an earlier age than it does in the male. We see pubic and axillary hair growing and hips widening. Genitalia that belong to the female includes the mons pubis, labia majora and minora, the fourchette, the clitoris, the vaginal vestibule, urethral meatus, Skene's ducts, vaginal introitus, hymen, ducts of Bartholin glands, the cervix, uterus, ovaries, and fallopian tubes. You do need to understand that the ovaries are going to produce female hormones, progesterone and estrogen. And the ovaries will contain all of the eggs that a woman will require when she is born for her entire life. And this is the female anatomy externally and the female anatomy internally. We need to look at the pelvis. The pelvis has 3 different functions. It supports and distributes body weight, it supports and protects pelvic organs, and it forms the birth passageway. There are 4 types of pelvis, and most women are going to have a combination pelvis. We look at the gynecoid, which is the round shape, and it is the optimum shape for passage of the fetal head. The anthropoid shape is a long, narrow, oval shape, and with this type of pelvis, a woman is more likely to deliver a baby with an occipital presentation. In other words, it will be face up. The android is a wedge shaped, and this is more common to the male. And the platypelloid is a shortened diameter front to back, and then it's a flat oval shape from side to side. It is very unfavorable for a vaginal delivery. But irregardless of the shape of the pelvis, the diameter has to be adequate if we're looking at a woman to have a vaginal delivery. Next, we look at the breasts. They're also called mammary glands. They produce milk for nourishment and maternal antibodies following delivery of a baby. They consist of the nipple, the areola, which is the darkened area surrounding the nipple, Montgomery glands, which are sebaceous glands in the areola, lobes, there are 15 to 24 in each breast, alveoli, which are lobules that will secrete milk, lactiferous ducts, which carry milk to the nipple, and lactiferous sinuses, which are an area of the ducts where the milk is temporarily stored. Breast size is determined by the amount of fatty tissue in the breast. It's very important when we talk about women's health to talk about women's preventive health. It's an important area of nursing in which education is the key. Women need to know the frequency of exams and the appropriate techniques for performing self-exams. Talking about breast exams, we're looking for lumps or lesions or unusual drainage. We need to encourage annual professional exams. A mammography is completed only as appropriate, but the American Cancer Society recommends that it is annual if the woman is 40 years and older, but earlier if she's at high risk. Vulvular exams should be completed by women over age 18, and we're looking for lesions or masses by palpating and inspecting. Pelvic exams identify infections, lesions, tumors, etc. in the vagina, cervix, uterus, and the ovaries, and it can also include a rectal exam. Preferably, it should be completed between menstrual cycles, and you should discourage sexual intercourse 48 hours prior, because if a pap smear is done, which it usually is with a pelvic exam, it can alter those results. A pap smear is done to identify precancerous tissue. We begin those pap smears at age 21, and then every 3 years from age 21 to 29, and backing off to every 5 years from age 30 to 65. If a woman reaches 65 years of age and she's had negative results for 10 years, pap smears are no longer recommended. We need to educate women on how to prevent vaginal infections, and this also goes for preventing UTI infections. We need to encourage the wearing of cotton underwear, discourage wearing of tight-fitting nylon clothing, encourage women to always wipe front to back after toileting. Douching should be discouraged or should only be minimal because it changes the natural flora of the vaginal vestibule and it can encourage bacteria to grow. And also encourage a healthy diet to strengthen the immune system. When we're talking about gynecological infections, there's 3 main types that we look at. We have toxic shock syndrome, sexually transmitted infections, and pelvic inflammatory disease. Now we'll look at each one of these a little bit more in depth. Toxic shock syndrome is rare and it is potentially fatal. It's caused by trapping bacteria in the reproductive tract for a prolonged time. We have an increased risk with high absorbency tampons, diaphragm or cervical cap use. There is a decreased risk with appropriate client education. Always encourage appropriate hand washing. Encourage women to change tampons at least every 4 hours and to use pads at night instead of tampons. Discourage the use of the superabsorbent tampons and discourage use of diaphragm or cervical cap during the menstrual period, and then remove it as soon as it is recommended. Treatment for toxic shock is supportive, and it may include vasopressor drugs, antimicrobial drugs, and fluid replacement. Sexually transmitted infections, many of these must be reported to the health department. Education is very necessary to prevent STIs. Abstinence is the only true prevention. Some barrier devices such as condoms can help prevent transmission, but it does not guarantee prevention. Education must be provided that the client must complete treatment and that all partners must be treated. If the partners are not treated, they're just going to pass the infection back and forth. HPV, or the human papillomavirus, is the most common viral infection in the sexually transmitted infections. Gonorrhea is the second most common infection, and it is the leading cause of blindness in newborns. Sexually transmitted infections can cause infertility, they can lead to cancer, and cause all kinds of issues. And don't forget that STIs can be transferred to newborns at delivery. To diagnose an STI is usually done with cultures and identification microscopically, and also visual inspection. Most treatments include antibiotics and removal of HPV growth, but understand that some STIs are lifelong. Excuse me, and that you will never get rid of some STIs. Pelvic inflammatory disease symptoms are going to include fever, chronic pain, abnormal vaginal discharge, nausea, anorexia, and irregular vaginal bleeding. We treat it with education, antibiotics, and once again encourage minimal to no douching. Menstruation is the periodic uterine bleeding that begins approximately 14 days after ovulation. The hypothalamus will produce hormones that stimulate the pituitary gland to produce the follicle-stimulating hormone and the luteinizing hormone, and it begins the maturation process of the ovum. The follicle-stimulating hormone, or FSH, and the luteinizing hormone, or LH, will stimulate the ovaries to produce estrogen and then progesterone. The luteinizing hormone surge also stimulates the release of mature ovum meaning an egg. In response to the estrogen and progesterone, the endometrium, or the lining of the uterus, will then proliferate and begin to shed. Menstrual frequency. Again, menarche is the first menstruation, and in North America this will occur in most girls at about age 13. Initially, menses are irregular, they're unpredictable, they're painless, and they may be anovulatory, which means that no egg is released from the ovary. A year or more later, the ovulatory periods will become more regular, but pregnancy usually will not occur until the menses are ovulatory, in other words, eggs being released from the ovaries. The average length of the menstrual cycle is 28 days, plus or minus up to 2 to 5 days. The average duration of the menstrual flow is 2 to 5 days. The average blood loss is only 30 to 40 mLs. The discharge consists of blood, mucus, serous fluid, and epithelial cells. Age, physical and emotional status, and environment influence the regularity of menstrual cycles, as does exercise. Ovulation is the release of mature ovum about 14 days prior to the onset of the menstrual period. The egg or eggs that are released from the ovaries are fertile approximately 5 to 7 days in the middle of the time frame between menses. Climacteric and is also known as the perimenopausal period. It's the transitional phase during which the ovarian function and the hormone production decline, and it lasts about 4 years. It spans the years from the onset of the premenopausal ovarian decline to the postmenopausal time. It is marked by irregular menstrual cycles, and these menstrual cycles may be anovulatory. In other words, they may not release any eggs. But don't go under the assumption that pregnancy cannot occur, because pregnancy can occur during this phase of life, and contraception should always be considered. During this time, periods may be missed, bleeding may be shorter or lighter, or it may be longer and heavier, and clotting may be present. Obese women are more likely to experience dysfunctional bleeding, as the estrogen is stored in body fat. Hormonal changes result in the symptoms of hot flashes and flushes and night sweats, with hot flashes being the most common symptom of the menopausal woman. No conclusive evidence that hormonal changes are responsible, though, for the majority of behavioral, emotional, and mental issues. Women may also have a decrease in vaginal secretions and elasticity of the vagina, which may cause painful intercourse. Osteoporosis and coronary heart disease are the major health risks of perimenopausal women. Cigarette smoking and short intermenstrual intervals seem to decrease the age of onset of the climacteric period. African American women and Hispanic women experience menopause earlier than most Caucasian women. But hereditary is the major determinant of age at menopause. Menopause is actually defined as the last menstrual period, but it can only be dated 1 year after menstruation actually ceases. The average age of natural menopause is 51.4 years, with an average range of 35 to 60 years. Surgical menopause will occur when a woman has a hysterectomy and a bilateral oophorectomy. In other words, both ovaries are also removed. Postmenopause is the time after menopause. We see some changes in the female body at this time. Genital, we see thinning vaginal membranes, increased dryness. The uterus, vulva, and distal portion of the urethra will also shrink. This may lead to urinary frequency and stress incontinence. And vaginal relaxation can lead to a cystocele, a rectocele, and uterine prolapse. Decrease in estrogen at this time in life causes an imbalance between bone formation and resorption and leads to osteoporosis. The menopausal hormonal therapy is only recommended for women who have specific discomforts and for women in certain high-risk groups. These women are at an increased risk for blood clots, heart attack, stroke, and invasive breast cancer if they have a long-term hormonal therapy replacement. And just a chart that shows or helps demonstrate the female reproductive cycles. There's many menstrual disorders, and we start off by talking about amenorrhea, which is the absence of the menstrual flow. In other words, no period. This is normal after menopause, during pregnancy, and before menarche. Clinical symptoms can be a variety of disorders, such as or then we look at causes that are pregnancy, anatomic abnormalities, anterior pituitary disorders, polycystic ovary disease, hypo or hyperthyroidism, type 1 diabetes, some medications such as phenytoin or Dilantin, drug use, oral contraceptives, anorexia nervosa, and exercise-induced amenorrhea. Uh, as I said in the previous slide, estrogen is stored in body fat, and women who exercise heavily do not have the excess body fat, so they don't have that storage of estrogen, so they're more likely to have missed periods that are normal than women who are heavier. We treat amenorrhea by determining the cause and treating it accordingly. There's two different categories of amenorrhea. We have primary, which is no menstruation by the age of 16, or by age 14 if there are no secondary sexual characteristics that have developed. And secondary, which is no menstruation for 3 cycles, or 6 months in a woman who has had regular cycles. Mittelschmerz is discomfort around ovulation, and that is treated with mild analgesics. This is a German term, and it means basically the middle. Dysmenorrhea is painful menses. We usually have pain in the suprapubic area or the lower abdomen. It can be sharp, cramping, gripping, steady, dull ache. It can radiate to the lower back or the upper thighs, and it may be accompanied by diarrhea, nausea, and vomiting. It's associated with those women who have an early menarche, who are nullipara, which means they have never been pregnant, and stress. Primary dysmenorrhea begins about 6 to 12 months after menarche, and it's not associated with underlying pathology. In other words, there's no particular reason why it happens. And secondary dysmenorrhea is acquired menstrual pain that develops later in life, typically after the woman is 25 years old, and it's associated with pelvic pathology, such as an endometriosis or PID. We treat it by identifying the cause: heat, massage, relaxation, yoga, acupuncture, exercise, dietary changes, NSAIDs, oral contraceptives, and alternative therapies. And premenstrual syndrome and premenstrual dysphoric disorder. The PMS is mood or somatic symptoms that will occur with menstrual cycles caused by an abnormal serotonin response to the normal changes in estrogen levels. We will not see PMS without ovarian function. It includes physiologic and physical symptoms, such as fluid retention, behavioral or emotional changes, premenstrual cravings, headache, fatigue, and backache. Now, premenstrual dysphoric disorder is a more severe variant of PMS, with only 3 to 8% of women having marked irritability, dysphoria, mood lability, anxiety, fatigue, appetite changes, and a sense of feeling overwhelmed, with mood disturbances being the most common. There's a variety of suggested treatments for these two disorders. They include limiting or avoiding certain foods or substances, such as smoking, salt, alcohol, caffeine, and simple sugars. Making sure the woman eats an appropriate diet, takes nutritional supplements, exercises, and medications such as diuretics, NSAIDs, and oral contraceptives. A home remedy for PMS symptoms can include herbal compounds, and a few sips of dill pickle juice has been shown to help with the headaches and cramping, and that comes straight from the doctors. Endometriosis is characterized by the presence and growth of endometrium-like tissue anywhere outside of the uterus. Endometrial tissue will grow during the proliferative and secretory phases of the menstrual cycle, and it bleeds during or immediately following menstruation, and it results in an inflammatory response with fibrosis and adhesions. Symptoms will include pain, dysmenorrhea, painful intercourse, bowel symptoms, abnormal bleeding, pain with exercise, chronic fatigue syndrome, fibromyalgia, autoimmune disorders, infertility, hot flashes, and vaginal dryness. There is basically not a lot of treatment that can be done other than NSAIDs, oral contraceptives, hormonal antagonists, laser ablation, and surgical intervention. And unless the entire unless a complete total abdominal hysterectomy with bilateral salpingo-oophorectomy is done, it can recur. Now, pregnancy can also treat these symptoms by keeping them at bay for the duration of the pregnancy, but after the pregnancy it all comes back. Oligomenorrhea or hypomenorrhea. Oligomenorrhea is infrequent menstrual periods that are characterized by being 40 to 45 days or longer in between periods. And hypomenorrhea is scanty bleeding, but it's at the normal intervals. Again, you determine the cause and treat it accordingly, but understand that it may be the normal pattern the first several years after menarche or before menopause. Metorrhagia is intermenstrual bleeding that refers to any episode of bleeding, whether it's spotting, a full menses, or hemorrhage that occurs at any other time than the normal menstruation. Causes can be oral contraceptives or IUDs, and again, treatment is going to depend on the cause. Menorrhagia or hypermenorrhea is going to be excessive menstrual bleeding that is over 80 mLs per cycle. Causes can be hormonal disturbances, systemic diseases, neoplasms, infections, and IUDs. And again, treatment is going to depend on the cause. And dysfunctional uterine bleeding is any form of uterine bleeding that is irregular in amount, duration, or timing and not related to regular menstrual bleeding. It can also be excessive uterine bleeding with no demonstrable organic cause, genital or extragenital. Treatment is conjugated estrogen daily, followed by the addition of progesterone, a D&C, which is a dilatation and curettage, for severe bleeding and hemorrhage, and ablation of the endometrium through laser treatment. Again, Depo-Provera is not just for birth control. Pelvic floor dysfunction occurs when the muscles, ligaments, and fascia supporting the pelvic organs are damaged or weakened. A cystocele is where the anterior vaginal wall becomes weak and it can no longer support the bladder. Stress incontinence is very common at this point. A rectocele is the posterior vaginal wall becoming weak, where feces can press on the vaginal wall rather than toward the anal sphincter. A uterine prolapse is where the uterus will sag into the vagina, and this is more likely following multiple vaginal births or births of large infants. Symptoms can include pelvic fullness, dragging sensation, pelvic pressure, fatigue, and low backache. Urinary incontinence is uncontrollable leakage of urine from the bladder, and it is very common after childbirth trauma. Uterine fibroids are benign growths of uterine muscle cells, and again, it's more common during childbirth years, but there is an increased risk with nulliparity and obesity, Oral contraceptives can decrease this risk. Symptoms will include irregular bleeding, bladder and pelvic pressure, dysmenorrhea, and menorrhagia with blood loss over 200 mLs per month. It can be treated with surgery or other medical treatments. Ovarian cysts. We have a couple of different types. We have the follicular cyst, which will develop if the follicle does not rupture and release the ovum during menstruation. These will usually resolve on their own. The lutein cyst develops when the corpus luteum fails to regress following ovulation, and it is the more painful. And polycystic ovary syndrome, which is an endocrine disorder. Symptoms will include obesity, infertility, amenorrhea, and excessive hair growth. It can lead to diabetes type 2, increased lipids, and heart disease. It's treated with diet, medications, surgery, and psychological support.